Good morning. I'd like to first thank the organizers for inviting me to speak. Sorry for those of you who thought David Balshaw was going to be presenting now, so you'll have to suffer through a half hour before he speaks. Bob and I started talking about me contributing to this conference a couple years ago, and I'm like, I don't really do that much AD research. I'm a neurologist, Parkinson's expert, but I see people with dementias and all sorts of other conditions inadvertently many times. But he sort of lit a fire under us to start to think more about expanding the work we're doing. And so what I'm going to describe today is a platform for sort of taking a different approach to exposomics and really addressing some of the comments that Remy made yesterday and several of the other presenters made. I'm a clinician, so there'll be a bit of a slightly more clinical leaning to this talk, but for the most part, this is a talk about using sort of cutting-edge geospatial methods to understand the contributors to the environmental contributors to neurodegenerative disease. Just advance. These are I have no disclosures. This is the grant funding for our lab currently. So overall, I'll start with an introduction to Medicare research because the methods that we'll be discussing today are primarily using administrative claims data to study Parkinson's and ADRD, and then a bit of an introduction to how we approach exposomics and the concept of geospatial neuroepidemiology. Show some examples of Parkinson's disease where where our work started, and then some mostly unpublished but rapidly developing work in ADRD. One of the challenges that we sought to address when we started to use Medicare data is a comment that Remy was making yesterday about sample size. So when I first started doing research in Parkinson's in the 90s, a large environmental study in Parkinson's involved maybe 1,000 patients. But we said, well, a lot of what we know about Parkinson's risk factors came from some of that work and some parallel work, and that's why most of what you hear with Parkinson's is pesticides cause Parkinson's. That's a very probably overstated in terms of the role of pesticides, but it's the focus has been almost exclusively on pesticides, until more recently. So we asked the question, what would happen if you just blew up that sample size? And Medicare allows us to do this. So what is Medicare? So for those of you who are not from the United States, Medicare is the only national health insurance in the United States. We can purchase these data, and they come with complete demographic data, race, age, sex, diagnoses, date of death. You can purchase in different ways. We tend to purchase by a primary diagnosis of interest and create retrospective cohort studies. And then each beneficiary can be tracked forward and back in time using a unique beneficiary identification number. We can geocode beneficiaries down to the 9-digit zip code, and that won't be intuitive if you're not from the United States, and even if you are, it may not be. Those are actually mail routes, but they can be as specific as a building in urban areas, but in rural areas they can be quite broad. So that is one of the challenges of geocoding, is that our precision is much better in urban areas. We can link these to environmental data sets, and we can conduct a variety of types of research. Most importantly today, we'll talk about spatial epidemiology. So some advantages and disadvantages of using Medicare. They are generally population-based, but only for the population 65 and older. So you're not eligible for Medicare until you're 65 years, or if you're on disability or have certain conditions. But for the most part, for this talk, these are people who are 65 and older. Of course, you get great statistical power. There's just some examples of that. Because the data are submitted for claims for physicians to be paid, physicians in hospitals. Physicians pay more attention to that, so they are audited. They can be used for discovery or hypothesis testing. So I'll provide examples of both. A lot of our PD work is really hypothesis testing, but the ADRD work we're doing is really trying to use this exposomics concept to do some discovery work to identify novel risk factors. They're useful for identifying minority populations that are almost never included in most environmental studies. And as I said, we can link to other data sets, and I'll show you what I mean in a second. One of the challenges is exposure lagging is limited, and we heard several presentations yesterday where presenters discussed the long lag time between the neuropathology evolving in the brain and when the disease actually is diagnosed. And that's a challenge that we don't have a solution for, because we only can identify people and track their residential location once they hit age 65. They don't have the granularity of electronic medical records data. And just a couple larger comments. The data these are large data, they're expensive, cost about a complete set of PD data, for example, is about $40,000 or $50,000 per year purchased. And the fun thing about that is that if you have an NIH grant to do work with these, you still have to pay the $50,000. So it's not, there's no bypassing that CMS operates this. It's separate in terms of its cost center in the government. So it's an expensive set of data to own. These are the data use agreements we have with Medicare right now. All total, over 40 billion records of data that we have in our lab, and this is what we've accumulated over the last 15, 16 years. I'll focus today on work from a PD data set, which, early data set, which has 100,000 PD cases. You see the size of the scale we're discussing here. A more recent PD data set with about 300,000 PD cases. And then our Alzheimer's cases are in the range, each incident year is about 500,000 incident AD cases, about 700,000 all-cause dementia. And then we have a new frontotemporal dementia data set that's about 50,000 cases. So just to give you a sense of why we like these methods, these are big sample sizes and that are just have not been used in these diseases previously. So we merged these data. So on the left, you see examples of environmental data sets that are publicly available in the United States. And then we merged them with the CMS data, and these are diseases that we're actively studying on the right. In addition to these, which are some of our richest data sets, we have one DUA that has over 2,000 neurologic diseases identified in 2018. So we can study almost anything now with the resources that we built. We linked these down to the claims data down to the zip 9 level, in most cases, sometimes zip 5, depending on how common disease is, because there are some limitations to what we can report out. And then the environmental data generally links to the census tract, which we can merge into the same geospatial level of certainty. And then we take a series of approaches. I'm going to show sort of different versions of the way we approach this. First of all, we map the standardized incidence. And this is sort of, I find this to be a really good first pass of how is the disease distributed through the United States. The United States is highly geographically, geologically, and ethnically different throughout the entire United States. So there's a lot of variability that we can use to our advantage. And then the next step typically is we do a nationwide regression to look at the association between the disease and the exposure. And then we're interested in not just is the exposure associated with disease, but where is that associated? So we want to understand. So, for example, paraquat is often cited as a risk factor for PD. Probably is, but it's not used everywhere in the United States. And so it makes sense that association is only going to be seen in certain areas. And so we're interested in where PD or other diseases are associated with environmental chemicals, because we recognize that there are probably dozens of associations, dozens of causes, and it's regionally specific as to what is the risk factor in those areas. And that's what on the third panel you see what a special correlation map, which is called by Lisa. This is a somewhat adjusted map, so it's standardized incidence is the input, and we look at high exposure, high incidence of disease, and then low as the areas where you see the strongest correlation. And on the bottom right, you see a geographic weighted regression, which is where we can provide the strongest evidence for an association between exposure and disease. So I'll show you various examples of the way we use these methods over the last several, in particular these methods we've used in the last 5 years or so. Okay. Start off with 3 diseases that we'll talk about over the next few minutes. So on the left, you see a standardized incidence ratio of Parkinson's disease in the United States. And so the first thing you'll notice, this is a disease that's not evenly distributed through the United States. And this has been published in numerous ways. We first published this back in 2010. And just the incidence map alone, the risk of PD in the sort of Rust Belt up in the Northeast is 10-fold greater than in California. Very strong evidence that something's not right there in that part of the country. And we still don't really totally understand this. There's definitely a concentration along the Ohio River Valley and the Mississippi River Valley. And in this case, you'll see that sort of spotty areas throughout the industrial East. The all-cause dementia map is very much in that band in the South, which is the stroke belt, where the area where we have sort of the worst health at all possible, almost all possible outcomes, cancer and cardiovascular disease. And then this is brand new work that Ben Schumacher in my lab has done recently. You see the concentration of frontotemporal dementia in the sort of the center of the country, and this is very raw. We've only did this because Bob challenged us to do this in the last few weeks, but it's pretty confident this is a true pattern. The explanation for it, though, we're still working on. Okay, so how do we approach this? So this is work that Brittany Kurzanowski published back in 2023, looking at the relationship between PM2.5 and Parkinson's disease. PM2.5 is, of course, associated with many health outcomes. There was less data at the time on Parkinson's disease. And you see, she took this in this case, this is 100,000 incident PD cases from 2009. We looked at exposures 10 years prior to diagnosis, still within a prodromal window, so not perfect, but it's at least temporally appropriate, which is an improvement upon many of the studies that have been done. And you see the spatial correlation. You see high incidence of PD and PM2.5 in some of those same areas in the Midwest where we saw the clustering, and then low in the mountain states. You see a relatively linear up to about 12 micrograms per meter cube of PM2.5. And what's interesting here, important, is that you see a linear dose response even below the National Ambient Air Quality Standards for PM2.5. So there's a pretty compelling relationship between PD and PM2.5. But interestingly, when you do the geographic weighted regression, we actually don't see that the strongest, the red signals where you see the strongest beta coefficients, the strongest coefficients are actually in that low area. So, and interestingly, that low area is where is in that first part of the curve where you see the steep dose response. The Midwest is you have the higher concentrations, and it really levels off, which Bob and I have discussed in a couple meetings, sort of typical of many environmental neurotoxicants. So this is yet another example of a hypothesis testing. So there's been some discussions or a couple papers that suggest that exposure to trichloroethylene is associated with Parkinson's disease risk. These studies were fairly limited to military populations and whether people had been in an area where they consumed water that was contaminated with TCE. So we looked at airborne TCE in the United States in relation to PD risk, and I'm just showing you another unique method that we've applied to this paradigm. So on the left, you see a dose-response relation between TCE in the air and PD risks. TCE levels on the x-axis and PD risk on the y-axis. And in the map, you see the emitters of TCE in the United States. So these are the areas in the country where TCE is emitted the most. And on the right, you see a different method called MapGAM, which creates a risk surface emanating from a specific point source. So this particular point source is in Oregon, where there's a TCE emitting facility that had been investigated by EPA, and the risk I think it's as much as 14-fold greater as you get closer to the facility, and then the risk reduces as you get further from the facility. So this is a way for us. So for air pollution, of course, air pollution is distributed throughout the United States, and it comes from a variety of sources. TCE is primarily going to be a point source. And so in this case, we can not only identify the relationship nationwide, but we can tell you exactly where that risk is occurring and the facilities that are probably the greatest concern. So Bob thinks I doubt him, and I don't listen to his comment to what he says. We also asked the question, does TCE affect the phenotype? So Parkinson's disease is sort of clinically we see a couple initial phenotypes. A tremor predominant version, it tends to be a little bit more slowly progressive, and then a gait predominant version is more rapidly progressive. And so what we find is, in fact, we do see a relationship, a dose-response relationship between TCE exposure and the phenotype. And this is using an assortment of codes to capture gait abnormalities, dementia, and falls. And so you see that only the gait dementia variant of PD do you see this dose-response relation? So phenotype probably is influenced by environmental risk factors, and we've seen this in manganese, where a lot of our work is as well. So we have done this in AD, and this is not particularly surprising to anybody that we can demonstrate that on the left, this is a BILISA again, showing high exposure to PM2.5 and high AD risk. And on the left and on the right, you see a somewhat flatter dose-response relation between annual PM2.5 and relative risk of AD. So dozens of studies have shown this, but just sort of proof of principle, we can see pretty much the same thing using in AD-RD as well. All right, that's not very interesting because other people have done that, but it's sort of proof of principle, yes, we can study this disease. But not all geospatial clustering is due to the environment. So AD is much more complicated. PD is a great disease to study because it's probably has mostly environmentally mediated. I mean, there's and we can debate that over coffee later, but PD is definitely a more clearly environmental disease. AD is much more complicated. So what you see on the left is the SIR for all-cause dementia, and it's the BILISA looking at the correlation between cardiometabolic disease. This is 8 diseases coded in what we call the CCW. A very rigorous way of identifying people with stroke and various forms of heart disease and hyperlipidemia. And this is work done by George Carway in my lab. On the right, you see the population attributable fraction of CMD on dementia. And what you see is in that area of the country in the south where we see the stroke belt with the worst health, we see that you see the greatest population attributable fraction of CMD on dementia. As much as 60% of all-cause dementia in these counties, this is county level research work, can be attributed to cardiometabolic disease. So huge public health message here. This is where the money is with all-cause dementia. You've got to address these risk factors that we all know are really important. So that makes, obviously, AD more complicated. You have to address and you have to adjust for cardiometabolic disease in your models. So this is some more work done by Brittany Kurzanowski and Vishal Harner, a medical student in the lab. So Brittany looked at a subset of PM2.5 in relation to all-cause dementia risk, and we see that you pretty much see a dose-response relation for traffic-related air pollution and all sort of subcomponents of traffic air pollution. This is data from NEMO. And I flipped the paradigm a little bit. So in the graph on the map on the top right, you see a GWR showing where in the country you see the greatest relationship between traffic-related air pollution and all-cause dementia risk. And on the bottom, we put the BILISA in this way on purpose because if you wanted to focus on cities where you have the highest PM2.5 and highest dementia risk, but also where you see the highest coefficients, it's Boston, New York, and St. Louis where you'd have the greatest impact public health-wise. So flipping the paradigm a little bit to sort of identify where can we intervene at the environmental level to have the greatest public health impact. I'll finish with the FTD work that Ben Schumacher has been doing in the lab. And so Ben, this is the only work that I'm showing today that's sort of truly sort of discovery-based in Silico Exposomics. So Ben took 175 nanochemicals in a unprecedentedly large study of frontal temporal dementia, for almost 48,000 cases and 190,000 controls. And we identified 24 toxicants that were associated with FTD after adjusting for multiple comparisons. The top signals were this group of 9 industrial solvents in the environment measured in NATA. So yes, where do we see it? Does this explain that clustering in the United States? Absolutely not, unfortunately. So we got some work to do on that. But interestingly, these are very highly correlated. So you have 2 groups of solvents. One group that's that's represented on the left with trimethylpentane. You see this clustering of beta coefficients in California, into Georgia and the Carolinas, and up into the Northeast. And then hexone, you see some overlap, but really you don't see that southeastern portion. So we have some evidence that, at least in certain parts of the country, that frontal temporal dementia is related to industrial solvent exposure. And this is a disease where almost no research has gone into environment. It's almost exclusively focused on biomarkers and pathophysiology of tau and genetics. About 30% of this disease is genetic, but 70% is not, but nobody focuses on this piece. And this is and we approached FTD because its phenotype is unique enough that we believe it's more identifiable in claims data. So conclusions, PD and AD and FTD have unique geospatial disease patterns. PM 2.5 increases risk of PD and AD, but the risk varies throughout the United States. TCE increases the risk of PD, and specific facilities may contribute to this risk. And then AD is associated with TRAP, especially in St. Louis, New York, and Boston. Bob, you've lived in 2 of those. I've lived in one of those. And then FTD may be associated with exposure to industrial solvents, a brand new area that we're hoping to explore in future work. So I invite you to visit us if you are ever in town in in Phoenix. I've spent 2 years in St. Louis. So this is the Barrow Neuroanalytics Center where my lab and other labs are based, where all of our environmental work is based, as well as other labs. About 20,000 square feet of dry lab space, all dedicated to computer-based research. And these are our funders, and of course we very appreciative to the dozens of people who've trained in the lab over the years. Okay, I'm done. Yeah.
Hi, great talk. Natalia Vilor-Tejedor from Utrecht University. Yesterday we were discussing, based on the Livingston curve, the impact of air pollution on dementia. And in Livingston curves, they reported at late life. I partially disagree. And actually we saw in some preclinical studies impact on amyloid positive individuals, etc., through more mechanistically neurovascular and inflammatory processes. I want to know your opinion about that.
So is the question on timing? Or the role of...
So they reported that air pollution impacts dementia late life. I think it's much more before. Yeah. What is your opinion, what you observe in your studies?
Yeah, I have lots of opinions on this, but no answers. When I see the presentations that talk about these windows, and Bob and I have talked about this, my wife and I have talked about this actually, I don't know what that relevant window is, but I do know that we rarely study it, and I don't actually know how to even begin to design a study to address that window. Because to do the studies that are needed, one, the sample sizes are massive to do the studies that are needed. This is what Remy was getting at yesterday. You need to say millions of people starting at a very young age to understand what those windows are. And we literally, the older people in the audience, me and Bob included, are not going to be around to see the results of the studies. These are very complicated studies to do. I don't know what that window is. And in PD, it's complicated because there are risk factors for PD that are formed, before teenage years, personality and other factors that are actually pretty important in PD risk. So I think there's a component of risk that's probably coded in very early on in life. But studying people at 50, is definitely not the right window, because we know that pathology is progressing. An 80 window is much longer than PD.
Thank you.
Brad, great talk. Just a question. So with the CMS data, you're dealing with people who are age 65. So you're actually looking at essentially where they live when they've retired or they're at age 65. But as we know, that there are a lot of exposures that happen much earlier in life. Yep. Do we have any sense of what percentage of the population in the United States is highly mobile?
Yeah.
So looking at something at 65 may not actually truly reflect. You may be seeing an impact of all those farmers from Wisconsin that are retiring in Texas and Florida.
Yeah, so very good question. So we do have data. I mean, every paper we write, we have to actually look at this. And we have the ability. So if we look at people who are 75, we have 10 years of data. So we can look at mobility in that range. And there are some data on this. About 85% of people are non-mobile. Now, I tried to get CMS to give me some data, I wanted to buy some data from them to get the first 3 digits of people's Social Security number. Because if we can get that, we know the general region that they live in, but they wouldn't let us have it. It's not identifying, right? Because it's just your region code, it's where you were born. And it would really allow us to kind of get at this a little bit, but CMS just wouldn't allow it. So I think there's opportunities. I mean, we talk about cohorts. I mean, Medicare is a giant cohort for us. If we can do a better job of harnessing that, I think there's some power to that. But the residential piece, if we could actually know people's lifetime residential history, this work is exponentially more powerful. But this is...
I'm sorry, Medicaid.
Well, but Medicaid's very biased, right? Medicaid's based to the poor, people with disabilities, and so it's you can use that, and it's very difficult to work with because the states manage it differently, so the data is much harder to clean and reconcile across the different states. So we've not done much with it because it's a huge hassle, and I don't think it's going to have the same breadth and power that we would see with Medicare.
Hi, Rolf Meulen, Utrecht University. Thanks for a wonderful talk, and I will build on that later in this afternoon. Just a comment, because we have a somewhat US focused on what we can do with this kind of HR data. Just to ping in the European perspective, that within the census data of the Nordic countries, including the Netherlands, we do have complete residential histories. If you then look at how many people move, at least for the Netherlands, that's about 5% of the population per year. But the interesting thing is then that people do not change very much their exposure status. So when we look basically at mobility, that people that were high move, but are still most likely high in air pollution, and the ones that were low move in their vicinity, but stay basically in a low area. So there's basically, to come back to Rick, at least within the European data, good evidence that it is stable over time. And therefore, I would argue that this data, and I would argue perhaps also for the US, that it does have relevance also to reflect the earlier life exposures. But this needs more research, but I think this can actually be done.
No, I appreciate that. And we've done some work in Finland in the past, and one of the challenges is that Finland has 5 million people, right? It's the Maricopa County where we live has 5 million people. So you need the combination of these different studies to really sort of inform the field. No one of these is going to be the answer. And we do, obviously we all rely on convergence of data to really to provide the most conclusive evidence.
Hello, nice, great talk. So you've talked about some correlation between PM2.5, and then you've also talked about some correlation between chemicals. I'm wondering what's the reason for looking at those specific chemicals, and is there any correlation between PM2.5 and those chemicals specifically? Yeah.
So those specific chemical models, TCE and all solvents are adjusted for PM2.5. So we always address that because, they are correlated. So everything's adjusted to the extent you can. Now, there's some of these that are so correlated with PM2.5, or at least traffic-related pollution that you can't you really can't isolate that individual effect. So we're still teasing that out. So why those chemicals? So TCE, there have been a couple of military studies showing association with TCE. So we wanted to look at airborne TCE. So that was why we looked at that. And the FTD work was purely discovery based. It was purely to do some exploratory work to identify novel risk factors, because there just hasn't been work. It would be very difficult to even develop a hypothesis with FTD because people haven't done it. The work is, the funding has been almost entirely focused on these non-environmental areas. Okay, I'll give you plenty of time. Thank you.